ability to recognize their caregivers? Do they have persistent vomiting and retching? And this may indicate more severe injury. As we were talking about earlier, first sign of increasing intracranial pressure is persistent vomiting and retching. Prolonged seizure following an injury. Now, keeping in mind that instead of having what we're used to seeing as a seizure, an infant may exhibit lip smacking or bicycling movements. They could have preorbital ecchymosis, better known as raccoon eyes. Both eyes are black around them, and they didn't hit their face. Post-auricular ecchymosis, or battle signs, which of course are behind the ear. Are there neurological deficits and signs of increased intracranial pressure? Again, that would be the prolonged vomiting and retching. Or seizures. Do they have a decreased or altered level of consciousness now? Are they bradycardic? Do they have vomiting? Is their speech slurred? Is there decorrugate or decerebrate posturing? And are they having seizures? Do they have inability to track objects? Is their pulse pressure widened? Pupil dilation with sluggish or absence reaction to light, another thing you need to assess. Ataxia while sitting, crawling, standing, or walking. Do they have a bulging anterior fontanelle if the fontanelles have not closed? And as you remember, a bulging fontanelle can be a sign of increasing intracranial pressure. Now, the care strategies are aimed at controlling secondary brain damage, such as cerebral swelling and ischemia. We do our primary assessment, of course, which is our ABCDEs, provide adequate oxygenation, prepare for intubation if a pediatric Glasgow coma score is 8 or less, initiate an IV line and administer fluids as needed to maintain a systolic blood pressure of 80 to 90, no higher. And we avoid fluid boluses in children who are hypertensive, and we also provide spinal immobilization, and this is necessary for all children who sustain possible head or spine injuries during a traumatic event. And we also strive to maintain their normal body temperature to prevent an increase in intracranial pressure and that stress. Thoracic injuries. Now, the majority occur from blunt trauma. Penetrating injuries are not as common in children, but may occur as a result of firearm accidents and high-velocity mechanisms. Children, as we remember, have a soft, flexible rib cage that can be compressed a great deal without ribs breaking. A significant force may cause injury to underlying structures without associated rib fractures or external signs of trauma. This is what we have to keep in mind. They may have significant injuries internally without rib fractures. Now, immediate life-threatening thoracic injuries include the following: airway obstruction and injury, lung and chest wall injuries, open pneumothorax, tension pneumothorax, a hemothorax, which of course is the blood in the pleural spaces, and pneumothorax, which is air in the pleural spaces. Could have a hemopneumothorax, which is a combination of both, a flail chest, cardiac tamponade, and hidden thoracic injuries include a pulmonary contusion or a myocardial contusion. Okay, a little bit more in depth. An airway injury can be an airway obstruction related to maxillofacial trauma or occasionally laryngeal injury. Now, a closed pneumothorax. This is when a force causes a veoli to rupture. Air accumulates in the pleural space, leading to loss of the negative intrapleural pressure and partial or complete collapse of the lung. The child may be asymptomatic if the pneumothorax is small or can present with respiratory distress and tachycardia. visible or palpable unequal chest wall movement, decreased or absent breath sounds to the affected side, hyper-resonant note to percussion over the affected side, and if undiagnosed and treated, may become a tension pneumothorax. Now, an open pneumothorax, this occurs when a penetrating injury creates direct communication between the pleural space and the outside environment. The sudden equilibrium between the intrathoracic and atmospheric pressure causes collapse of the lung and a potential sucking chest wound. Signs and symptoms are proportional to the size of the wound, and they may present with respiratory distress and tachycardia. Visible chest wound, reduced breath sounds, and a hyper-resonant percussion note over the affected side. Of course, the treatment involves placing an occlusive dressing over the wound and tape down over 3 sides, only to create a one-way valve where the pressure inside can get out, but it won't let any more air in. Then we have the tension pneumothorax, which is the accumulation of air under pressure in the pleural space. This occurs secondary to damage to the lung parenchyma or bronchus. This is where air flows in during inspiration and is unable to escape during expiration, which progressively causes lung collapse. This eventually leads to mediastinal shift to the opposite lung, and this also reduces venous return. This rapidly leads to hypotension and circulatory collapse. This may occur to a greater extent in young children who have a more mobile mediastinum than adults. Children will present with severe respiratory and cardiovascular compromise, asymmetrical chest wall movement, decreased breath sounds to the affected side, distended neck veins, and in the late stage, tracheal deviation away from the affected side in older children. Immediate intervention includes, of course, a pleural needle decompression to the second intercostal space, mid-clavicular line. We insert a large bore IV catheter, and remember we insert it over the top of the third rib to avoid nerve and artery on the bottom of the second rib. We have the hemothorax. This occurs when blood accumulates in the pleural space, eventually leading to collapse of the affected lung. Children have a smaller circulating blood volume, so the accumulation of smaller amounts of blood may be significant enough to produce signs of hypovolemic shock. This usually presents with circulatory collapse followed by respiratory distress, cyanosis, dyspnea, tachypnea, or ventilatory compromise. Decreased chest wall movement, diminished or absent breath sounds on the injured side, flat neck veins, dullness to percussion on the injured side. Remember, hypotension tends to be a late sign in circulatory failure in children. Compensatory mechanisms may initially mask serious hypovolemia. Primary assessment with interventions as necessary. We start 2 large bore IV lines in place for volume replacement, if necessary, and prior to fluid removal. Okay, flailed chest and rib fractures. A flailed chest is when 2 or more ribs are fractured in 2 or more places, and a segment of the chest wall may be detached from the thoracic cage, resulting in paradoxical movement of the detached portion. Rib fractures occur less commonly in children than adults. The elastic nature of their more cartilaginous bone requires greater force to fracture. The presence of rib fractures indicates significant transfer of energy to the tissues that lie underneath. Now the child will breathe as shallowly as possible to decrease movement of the thorax and therefore decrease pain. Pulmonary contusion that results from a flail segment will impair gas exchange and lead to hypoxia and hypercapnia. Expose and examine the chest for decap BTLS, which is deformities, contusions, abrasions, punctures, penetrations, burns, tenderness,